severe aortic stenosis and TAVR. Joseph N. White, Jr., M.D. Maine Health Cardiology. Maine Medical Center. Clinical Assistant Professor. Department of Medicine. Tufts University School of Medicine. September 12, 2014. Disclosures. I will not discuss off-label use or investigational use in my presentation. I have no financial relationships to disclose. Employee of Maine Health Cardiology. Prevalence of aortic stenosis. 16.5 million people in U.S. over the age of 652. Aortic stenosis is estimated to be prevalent in up to 7% of the population over the age of 651. It is more likely to affect men than women. 80% of adults with symptomatic aortic stenosis are male. 3% diagnosed with aortic stenosis. Aortic stenosis is a common public health problem affecting millions of people in the United States. It is estimated to be prevalent in up to 7% of the population over the age of 65. It is also more likely to affect men than women. 80% of adults with symptomatic aortic stenosis are male. Aortic stenosis demographics. Aortic stenosis 2% U.S. population greater than 65 years old. Aortic sclerosis 29% U.S. population 65 years old. Aortic sclerosis 50% greater risk of mortality and myocardial infarction. Aortic sclerosis progresses to aortic stenosis in 9% over 5 years. What causes aortic stenosis in adults? More common. Age-related calcific aortic stenosis. Aortic stenosis in patients over the age of 65 is usually caused by calcific, calcium, deposits associated with aging. Rheumatic fever. There are various causes of aortic stenosis. Aortic stenosis in patients over the age of 65 is usually caused by calcific, calcium, deposits associated with aging. It can also be caused by infection, rheumatic fever, or a congenital abnormality. Adults who have had rheumatic fever may also be at risk for aortic stenosis. Congenital abnormality. In some cases adults may develop aortic stenosis resulting from a congenital abnormality. Less common, 3 major etiologies for aortic stenosis. Major risk factors. Independent clinical factors associated with degenerative aortic valve disease include the following: 4. Increasing age. Male gender. Hypertension. Smoking. Elevated lipoprotein A. Elevated LDL cholesterol. Independent clinical factors associated with degenerative aortic valve disease include the following: increasing age, male gender, hypertension, smoking, elevated lipoprotein A, elevated LDL cholesterol. Signs and symptoms: heart failure, carotid parvus tardus, angina. Syncope. Carotid parvus tardus. Laterally displaced PMI. SOFTA 2. Crescendo-decrescendo systolic murmur. Timing of peak murmur and not intensity predicts severity. Aortic stenosis is life-threatening and progresses rapidly. Literature shows survival after onset of symptoms is 50% at 2 years and 20% at 5 years. Surgical intervention for severe aortic stenosis should be performed promptly once even minor symptoms occur. Survival after onset of symptoms is 50% at 2 years and 20% at 5 years. 1. Surgical intervention for severe aortic stenosis should be performed promptly once even minor symptoms occur. 1. Sobering perspective: 5-year survival, 8 survival %. Data shows a sobering perspective for inoperable patients. 5-year survival of breast cancer, lung cancer, prostate cancer, ovarian cancer and severe inoperable aortic stenosis. Breast cancer, lung cancer, colorectal cancer, prostate cancer, ovarian cancer, severe inoperable as. Using constant hazard ratio. Data on file, Edwards Lifesciences LLC. Analysis courtesy of Murat Tuksu, MD, Cleveland Clinic. 5-year survival of breast cancer, lung cancer, prostate cancer, ovarian cancer and severe inoperable aortic stenosis. Echocardiographic guidelines are the gold standard in assessing severe aortic stenosis. 6. Echocardiographic guidelines are the gold standard in diagnosing a patient with severe aortic stenosis. According to the 2008 ACC/AHA guidelines, severe aortic stenosis is defined as aortic valve area, AVA, less than 1.0 square centimeters, mean gradient greater than 40 millimeters of mercury or jet velocity greater than 4.0 meters per second. Doppler echocardiographic measurements. According to the 2014 ACC/AHA guidelines, severe aortic stenosis is defined as aortic valve area, AVA, less than 1.0 square centimeters. Mean gradient greater than 40 millimeters of mercury or jet velocity greater than 4.0 meters per second. Multiple modalities may be used to diagnose severe aortic stenosis. 6. Transthoracic echo, TTE. Chest X-ray, electrocardiogram, cardiac cath, auscultation. Multiple modalities may be used to diagnose severe aortic stenosis, including review of a patient's electrocardiogram, chest X-ray, cardiac catheterization, auscultation and transthoracic echocardiography, TTE. Continuity equation conservation of mass. Echocardiography. Continuity equation conservation of mass. Echocardiography, 3D planimetry. Not so classic aortic stenosis. 1. Low flow, low gradient severe AS2. 1. Low flow, low gradient severe AS2. Paradoxical low flow, low gradient severe AS. Low flow, low gradient AS. Low gradient with a small calculated valve area in the setting of poor systolic function. This may result in lack of referral for AVR because of the low gradient. Dobutamine stress echo. By increasing cardiac output, we can determine if the AS is severe by reassessing the gradient across the aortic valve, increases, and the aortic valve area, decreases. Assess myocardial contractile reserve. Does the cardiac output improve by 20% or more? Critical for decision-making regarding aortic valve replacement. Paradoxical low flow and/or low gradient severe aortic stenosis. 1. Some patients with severe aortic stenosis based on valve area have a lower than expected gradient, for example mean gradient less than 30 mm of mercury, despite preserved LV ejection fraction, for example F greater than 50%. Up to 35% of patients with severe aortic stenosis present with low flow, low gradient. These low gradients often lead to an underestimation of the severity of the disease, so many of these patients do not undergo surgical aortic valve replacement. According to the 2008 ACC/AHA guidelines, severe aortic stenosis is defined as aortic valve area, AVA, less than 1.0 square centimeters, mean gradient greater than 40 millimeters of mercury or jet velocity greater than 4.0 meters per second. In patients with low cardiac output, a low gradient, less than 40 millimeters of mercury, may be present. In this case, accurate differentiation between true and pseudo-severe aortic stenosis is necessary. Dobutamine stress echocardiography should be used to better define the severity of the aortic stenosis in this circumstance. Dobutamine stress in low gradient, low ejection fraction as Chambers, Hart. 2006 April, 92-4, 554-558. Stages of valvular as ACC/AHA 2104 Valve Guidelines. Nishimura et al. Circulation. 2014 E521E643. Copyright American Heart Association Incorporated. All rights reserved. Summary of recommendations for AS, timing of intervention. Nishimura et al. Circulation. 2014 E521E643. Copyright American Heart Association Incorporated. All rights reserved. Aortic valve replacement greatly improves survival. Patient survival 16. AVR, no symptoms. AVR, symptoms. No AVR, no symptoms. No AVR, symptoms. Study data demonstrate that early and late outcomes were similarly good in both symptomatic and asymptomatic patients. It is important to note that among asymptomatic patients with SAS, omission of surgical treatment was the most important risk factor for late mortality. Years. Study data demonstrate that early and late outcomes were similarly good in both symptomatic and asymptomatic patients. It is important to note that among asymptomatic patients with SAS, omission of surgical treatment was the most important risk factor for late mortality. Options for aortic valve replacement. Inoperable or higher risk. Patients suitable for open chest surgery. Transcatheter aortic valve replacement, TAVR. Surgical aortic valve replacement. TAVR. Minimal incision valve surgery. MIVS. Transfemoral approach. Prosthetic heart valves. Tilting disc valve. Bioprosthetic valve. Low percentage of aortic valve surgery. Aortic valve replacement. No aortic valve replacement. Studies show at least 40% of SAS patients are not treated with an AVR 915. Studies show at least 40% of patients with severe AS are not treated with an AVR 915. Summary of recommendations for AS, choice of surgical or transcatheter intervention. Nishimura et al. Circulation. 2014 129 E521E643. Copyright American Heart Association Incorporated. All rights reserved. What is TAVR transcatheter aortic valve replacement? An aortic valve replacement as an alternative to traditional thoracotomy. Less invasive than traditional thoracotomy for patients considered too high risk for traditional surgery. If a cardiac surgeon determines that you are too sick for open heart surgery and if medicine is not helping you feel better, TAVR may be an alternative. This less invasive procedure allows your aortic valve to be replaced with a new valve while your heart is still beating. 2 TAVR options. Edwards Sapien valve, stainless steel frame. More aortic regurg, less avenue block/ppm. Better for severe bulky calcification. Medtronic core valve. Nitinol frame, self-expanding. Less aortic regurg, more heart block/ppm. TAVR multimodality imaging. Partner study design Cohort A. Cohort B N equals 358 inoperable high risk. Symptomatic severe aortic stenosis. Cohort A. Assessment, high risk AVR candidate. 3,105 total patients screened. Cohort B. N equals 179. N equals 358. Inoperable. Standard therapy. Assessment, transfemoral access. Not in study. TAVR. Primary endpoint, all-cause mortality over length of trial, superiority. Co-primary endpoint, composite of all-cause mortality and repeat hospitalization, superiority. 1-to-1 randomization. Versus. Yes. No. Total equals 1,057 patients. High risk. N equals 699. 2 parallel trials, individually powered. Assessment, transfemoral access. Transapical, TA. Transfemoral, DF. 1-to-1 randomization. Yes. No. TAVR. AVR. Primary endpoint, all-cause mortality at 1 year, non-inferiority. TAVR. Versus. N equals 248. N equals 104. N equals 103. N equals 244. Partner trial B exclusion criteria. Bicuspid or non-calcified aortic valve. Acute myocardial infarction. Substantial coronary artery disease requiring revascularization. Left ventricular ejection fraction of less than 20%. A diameter of the aortic annulus of less than 18 mm or more than 25 mm. Severe, greater than 3+, mitral or aortic regurgitation. A transient ischemic attack or stroke within the previous 6 months. Severe renal insufficiency, creatinine greater than 3 or on dialysis. Iliac femoral anatomy precluding safe sheath insertion. Partner trial B primary endpoints, death from any cause. Rate of a hierarchical composite of the time to death from any cause or the time to the first repeat hospitalization from aortic valve disease or procedure-related complication. Partner trial B secondary endpoints. The rate of death from cardiovascular causes. NYHA functional class. The distance covered during a 6-minute walk test. Valve performance, assessed by echocardiography. The rates of myocardial infarction, stroke, acute kidney injury, vascular complications, and bleeding. Characteristics of an inoperable patient Cohort B. TAVR patients may present with some of the following. Severe, symptomatic native aortic valve stenosis. Old age. Frailty. History of stroke CVA. History of syncope. Reduced F. Heavily calcified aorta. Prior CABG. Prior chest radiation. History of AFib. History of CAD. Prior open chest surgery. History of COPD. Fatigue, slow gait. History of renal insufficiency. Peripheral vascular disease. Diabetes and hypertension. Standard medical therapy. 179 patients assigned. Balloon valvuloplasty performed in 114, 63.7%, patients in first 30 days and 36, 20.1%, additional patients 30 days after randomization. 12, 6.7%, underwent AVR. 5, 2.8%, LV apex to aorta conduit. TAVR group 179 patients, 6 did not undergo TAVR. 2 died before implantation. 2 unsuccessful transfemoral access. 2 aortic valve annulus was too large. Cohort B survival. The partner trial Cohort B. Despite frequent BOF, 78.8%, standard therapy failed to alter the dismal natural course of the disease. The Edwards-Sapien transcatheter heart valve demonstrated an absolute reduction in mortality of 25% at 2 years. The partner trial Cohort B, Edwards-Sapien THV improved cardiac function. The dramatic reduction in mean gradient in the Edwards-Sapien transcatheter heart valve arm of Cohort B was sustained out to 2 years. The mean gradient worsened over time for the patients in the standard therapy group, with no sustained hemodynamic benefit from BOF. Error bars equals ±1 standard dev. The partner trial Cohort B. Cohort B HF improvement. The vast majority of patients treated with the Edwards-Sapien THV, who initially presented in NYHA class 3 or 4, were alive at 12 months. But perhaps as important, they were now mildly symptomatic or asymptomatic in class 2 or 1, respectively. 83% of the Edwards-Sapien THV patients were classified as NYHA class 1 or 2 at 2 years. Improvement was observed as early as 30 days, p less than 0.0001. The patients in the standard therapy arm didn't fare as well. The majority who did survive at 1 year still presented with NYHA class 3 or 4 symptoms. The partner trial Cohort B. Complications. The partner trial Cohort B. The Edwards-Sapien THV was associated with a higher incidence of stroke, major vascular complications and major bleeding at 2 years. Standard therapy demonstrated higher all-cause mortality as well as death or repeat hospitalization at 2 years. Stroke was defined as follows: neurological deficit lasting greater than or equal to 24 hours or lasting less than 24 hours with a brain imaging study showing an infarction. Major vascular complications were defined as any thoracic aortic dissection, access site or access-related vascular injury, dissection, stenosis, perforation, rupture, arteriovenous fistula, pseudoaneurysm, or hematoma, leading to either death, need for significant blood transfusion, greater than 3 units, or percutaneous or surgical intervention, and or distal embolization, non-cerebral, from a vascular source requiring surgery or resulting in amputation or irreversible end organ damage. Bleeding event is defined as greater than or equal to 2 units within the index procedure. The partner trial Cohort B. Partner study design Cohort A. Cohort B A equals 358 inoperable high risk. Symptomatic severe aortic stenosis. Cohort A. Assessment, high-risk AVR candidate. 3,105 total patients screened. Cohort B. N equals 179. N equals 358. Inoperable. Standard therapy. Assessment, transfemoral access. Not in study. TAVR. Primary endpoint, all-cause mortality over length of trial, superiority. Co-primary endpoint, composite of all-cause mortality and repeat hospitalization, superiority. 1-to-1 randomization. Versus. Yes. No. Total equals 1,057 patients. High risk. N equals 699. 2 parallel trials, individually powered. Assessment, transfemoral access. Transapical, TA. Transfemoral, TF. 1-to-1 randomization. Yes. No. TF-TAVR. AVR. Primary endpoint, all-cause mortality at 1 year, non-inferiority. TAVR versus N equals 248. N equals 104. N equals 103. N equals 244. Cohort A, all-cause mortality. HR, 95% C, equals 0.93, 0.74, 1.15. P, log rank, equals 0.483. 44.8%. 34.6%. 44.2%. 26.8%. 33.7%. 24.3%. No. At risk. TAVR. 348. 298. 261. 239. 222. 187. 149. AVR. 351. 252. 236. 223. 202. 174. 142. Months post-randomization. Cohort A, strokes. 3.2%. 6.0%. 9.3%. 8.2%. HR, 95% C, equals 1.09, 0.62, 1.91. P, log rank, equals 0.763. 4.9%. 7.7%. Months post-randomization. No. At risk. TAVR. 348. 287. 250. 228. 211. 176. 139. 351. 246. 230. 217. 197. 169. AVR. Core valve US pivotal trials iliofemoral access greater than 18 FR sheath. Extreme risk. High risk. Core valve. Iliofemoral. Iliofemoral access greater than 18 FR sheath. No. Yes. Randomization 1:1. Non-iliofemoral. Versus SAVR. N equals 487. N equals 147. TCT 2013 LBCT. Extreme Risk Study, Iliofemoral Pivotal. Extreme Risk Study, Iliofemoral Pivotal. Study Purpose. Study purpose, to evaluate the safety and efficacy of the core valve THV for the treatment of patients with symptomatic severe aortic stenosis in whom the predicted risk of operative mortality or serious, irreversible morbidity was 50% or greater at 30 days. Risk determined by 2 clinical site cardiac surgeons and 1 interventional cardiologist. Risk confirmed by 2 screening committee cardiac surgeons and 1 interventional cardiologist. Primary endpoint, all-cause mortality or major stroke at 12 months. TCT 2013 LBCT. Extreme Risk Study, Iliofemoral Pivotal. Inclusion and exclusion criteria. Inclusion criteria. Severe aortic stenosis. AVA less than or equal to 0.8 square centimeters or AVA less than or equal to half a square centimeter /m2 and mean gradient greater than 40 mm Hg or peak velocity greater than 4 meters per second at rest or with dobutamine stress, if ELF less than 50%. NIHA functional class 2 or greater. Exclusion criteria, selected. Recent active GI bleed, 3 MOS, stroke, 6 MOS, or ME, 30 days. Creatinine clearance less than 20 ml per minute. Significant untreated coronary artery disease. LF less than 20%. Life expectancy less than 1 year due to comorbidities. TCT 2013 LBCT. Extreme risk study, iliofemoral pivotal. All-cause mortality or major stroke months post-procedure. Primary endpoint. All-cause mortality or major stroke. P less than 0.0001. Performance goal equals 43%. All-cause mortality or major stroke. 9.3%, 6.7, 12.0. 25.5%. 21.6, 29.4. Months post-procedure. TCT 2013 LBCT. Extreme risk study, iliofemoral pivotal. Percentage of patients extreme risk study, iliofemoral pivotal. NIHA class survivors. 90% of patients improved at least one NIHA class by 1 year. 60% of patients improved at least 2 NIHA classes by 1 year. Percentage of patients. TCT 2013 LBCT. Extreme risk study, iliofemoral pivotal. Extreme risk study, iliofemoral pivotal. Secondary endpoints. Events. 1 month. 1 year. Any stroke, percent. 3.9. 6.7. Major, percent. 2.4. 4.1. Minor, percent. 1.7. 3.1. Myocardial infarction, percent. 1.3. 2.0. Reintervention, percent. VARC bleeding, percent. 35.1. 41.4. Life-threatening or disabling, percent. 11.7. 16.6. 24.1. 27.6. Major vascular complications, percent. 8.3. 8.5. Permanent pacemaker implant, percent. 22.2. 27.1. Per ACC guidelines, percent. 17.4. 19.9. Percentages obtained from Kaplan-Meier estimates. TCT 2013 LBCT. Extreme risk study, iliofemoral pivotal. Core valve trial. 57. Study disposition. Primary endpoint, 1 year all-cause mortality. ACC 2014. 19.1%. 4.5%. Surgical. 14.2%. P equals 0.04 for superiority. 3.3%. Transcatheter. 59. 2-year all-cause mortality. ACC 2014. Major stroke. 62. Other endpoints events 1 month 1 year TAVR SAVR p-value. Vascular complications, major, percent. 5.9. 1.7. 0.003. 6.2. 2.0. 0.004. Pacemaker implant, percent. 19.8. 7.1. Less than 0.001. 22.3. 11.3. Bleeding. life-threatening or disabling, percent. 13.6. 35.0. 16.6. 38.4. New onset or worsening atrial fibrillation, percent. 11.7. 30.5. 15.9. 32.7. Acute kidney injury, percent. 6.0. 15.1. Percentages reported are Kaplan-Meier estimates and log-rank p-values. 63. MMC Heart Valve Clinic Marco Diaz, MD John Lualde, MD. David Butzel, MD Merle Kellett, MD. Reed Quinn, MD Scott Buchanan, MD. David Berkey Maryland. Evaluate the aortic valvular complex using echocardiography. Following patient referral, the TAVR team will perform further evaluation. 1, 2, 3, 4, 5. Confirm the patient is diagnosed with severe symptomatic native aortic stenosis. Confirm the patient has been independently evaluated by 2 cardiac surgeons and meets the indication for TAVR. Evaluate the aortic valvular complex using echocardiography. Evaluate the peripheral vasculature and aortic valvular complex using MDCT. Evaluate the peripheral vasculature and aortic valvular complex using catheterization. Note: evaluation using CT is typically not done unless the heart team confirms that patient is a candidate for TAVR. Key takeaways: aortic stenosis is prevalent with a high morbidity and mortality when symptomatic, and aortic valve replacement is the only treatment associated with improved outcomes. Asymptomatic low-risk patients will benefit from surgical AVR. Low gradient does not necessarily exclude severe aortic stenosis, even when the ejection fraction is normal. TAVR is an excellent alternative to traditional aortic valve surgery but increased risk of stroke and vascular injury and the need for a permanent pacemaker. MMC Heart Team has performed over 100 TAVR procedures in 3 years with excellent outcomes.